Welcome to our Renal and Genitourinary System review. This represents high-yield certification content that appears frequently on NNP exams. Renal disorders are tested heavily because they're common in the NICU and potentially life-threatening when missed. We'll focus on the clinical presentations, assessment approaches, and management strategies that ensure both excellent patient care and exam success. Every concept connects to real NICU scenarios where your clinical judgment saves lives and earns critical exam points. These objectives target core competencies that certification exams test most frequently in neonatal nephrology and urology. Renal embryology knowledge helps you connect developmental abnormalities to clinical presentations, like recognizing that oligohydramnios leads to Potter sequence and pulmonary hypoplasia. Clinical presentation recognition means differentiating pre-renal from intrinsic AKI and knowing emergency patterns like bilious emesis requiring immediate surgical consultation. Your systematic assessment approach must be automatic. Can you differentiate a hydrocele from an inguinal hernia? Do you know when to order renal ultrasound versus VCUG? Evidence-based management strategies include understanding that furosemide may help fluid overload in AKI, but won't change the underlying kidney injury course. Finally, complications and outcomes knowledge is essential because exam questions frequently test prognosis and follow-up care, like knowing neonatal AKI increases chronic kidney disease and hypertension risk. Renal embryology demonstrates a fascinating progression through 3 developmental stages. Understanding this sequence helps explain many congenital anomalies we encounter in the NICU. The Pronephros represents the earliest attempt at kidney formation, appearing and disappearing within the first 4 weeks of gestation. While it never functions as a true kidney, it establishes the foundation for subsequent development. The mesonephros serves a transitional role. It briefly functions as a primitive kidney, but more importantly, contributes to the development of reproductive structures. This shared embryologic origin explains why renal and reproductive anomalies frequently coexist, a clinical pattern worth remembering when evaluating infants with congenital anomalies. The metanephros becomes the permanent kidney, beginning its development at 5 weeks gestation. The timeline here is clinically significant. First nephrons form by 8 weeks, and nephrogenesis continues until 34 to 36 weeks gestational age. This protracted development has profound implications for premature infants. Consider that each kidney contains between 800,000 and 1.2 million nephrons at birth, a fixed endowment that must last a lifetime. No additional nephrons develop after 36 weeks gestation. Infants born extremely premature therefore begin life with a reduced nephron mass. This deficit creates a substrate for future renal insufficiency, as fewer functional units must handle the same physiologic demands. The clinical correlations are straightforward, yet important. Early embryologic disruption results in severe anomalies such as renal agenesis, while later insults produce dysplasia or hypoplasia. The timing of the insult predicts the severity of the anomaly. Understanding this developmental sequence allows us to anticipate associated abnormalities and long-term complications, ultimately improving our ability to counsel families and plan appropriate follow-up care. The metanephros develops through a remarkable interaction between 2 distinct tissue types, each contributing essential structures to the final kidney architecture. The ureteric bud emerges from the mesonephric duct and functions like a master plumber, creating the kidney's drainage system. It branches repeatedly to form the ureter, renal pelvis, major and minor calyces, and ultimately the collecting ducts. Think of it as building the entire plumbing network from a single starting point. The metanephric mesenchyme provides the functional tissue, the actual filtering units. This mesenchymal cap surrounds each branching tip of the ureteric bud and differentiates into nephrons, glomeruli, proximal tubules, loops of Henle, and distal tubules. Without this mesenchyme, you'd have drainage pipes, but no filtration system. What drives this complex choreography? GDNF-Ret signaling serves as the primary molecular conversation between these tissues. GDNF, secreted by the mesenchyme, binds to Ret receptors on the ureteric bud, triggering branching morphogenesis. This signaling must be precisely regulated. Too much causes cystic kidneys, Too little results in hypoplasia or agenesis. The clinical implications are profound. Mutations affecting GDNF-Ret signaling cause a spectrum of anomalies from unilateral renal agenesis to bilateral dysplasia. When evaluating an infant with renal anomalies, consider that the defect likely occurred during this critical interaction phase. The process completes by 34 to 36 weeks gestational age, which explains why kidney architecture is essentially fixed at birth. Understanding this dual origin development helps explain imaging findings. When ultrasound shows hydronephrosis, we're seeing dilated structures derived from the ureteric bud. When we identify poor corticomedullary differentiation, we're observing abnormal mesenchyme-derived tissue. This embryologic knowledge transforms abstract imaging findings into meaningful clinical assessments. Understanding normal renal anatomy provides the foundation for recognizing abnormalities in our smallest patients. Let's establish these baseline parameters that guide our clinical assessments. The kidneys occupy the retroperitoneal space, typically spanning from T12 to L3 vertebral levels. This posterior location explains why renal masses may not be immediately apparent on initial examination. When palpating for kidneys, remember to support the infant's back with one hand while gently pressing anteriorly. The retroperitoneal position requires this bimanual technique for proper assessment. Normal kidney size in a full-term infant measures 4.0 to 5.0 centimeters in length. This seemingly small measurement becomes critically important when evaluating ultrasounds. Kidneys measuring below 4 centimeters suggest hypoplasia, while those exceeding 5.5 centimeters may indicate obstruction, cystic disease, or compensatory hypertrophy. Always correlate size with gestational age. A 4-centimeter kidney in a 28-weeker represents normal development, while the same size at term suggests pathology. The nephron serves as the kidney's functional unit, and understanding its components clarifies many clinical findings. Each nephron begins with a glomerulus enclosed in Bowman's capsule. Think of this as the initial filter. The proximal tubule follows, where most reabsorption occurs. The loop of Henle creates the concentration gradient, the distal tubule fine-tunes electrolyte balance, and the collecting duct system provides final urine modification. The dual capillary bed system is unique to the kidney. Blood enters through the afferent arteriole, forms the glomerular capillaries for filtration, exits via the efferent arteriole, then forms paratubular capillaries for reabsorption. This arrangement allows the kidney to filter and reclaim simultaneously, an elegant design that becomes clinically relevant when considering how medications distribute and how renal injury patterns develop. Understanding this architecture helps predict which diseases affect filtration versus tubular function. Renal blood flow follows a unique pathway that directly determines kidney function. Let's trace this circulation and understand how it relates to the glomerular filtration rate values we monitor in our patients. Blood enters the kidney through the afferent arteriole. Think of this as the supply line. This vessel delivers blood to the glomerulus, where filtration occurs. What makes renal circulation special is what happens next. Instead of draining into a vein, blood exits through another arteriole, the afferent arteriole. This creates resistance that maintains glomerular pressure for filtration. The afferent arteriole then branches into peritubular capillaries that wrap around the tubules, allowing filtered substances to be reclaimed. This entire system depends on two factors: cardiac output and perfusion pressure. When blood pressure drops or cardiac output decreases, the kidneys suffer immediately. This explains why hypotensive episodes in neonates can trigger acute kidney injury so rapidly. The kidneys require adequate pressure to filter effectively. Now let's connect this to GFR values. Preterm infants less than 34 weeks gestation maintain a GFR of only 13 to 15 milliliters per minute per 1.73 meters squared. Why so low? Their afferent arterioles are still developing, nephron number is incomplete, and the tubular system remains immature. Term newborns show more variability, with GFR ranging from 15 to 60 at birth. This wide range reflects the rapid maturation occurring during the transitional period. The remarkable part is the trajectory. By age 2, GFR reaches adult levels around 120. This represents an 8-fold increase from preterm values. Understanding this progression helps us interpret laboratory values appropriately. A creatinine of 1.0 in a premature infant represents significant impairment, while the same value in a 2-year-old suggests normal function. The physiology drives the numbers. As renal blood flow patterns mature and nephrons fully develop, filtration capacity increases dramatically. This knowledge prevents us from over-treating normal developmental limitations or missing true pathology. The renal tubules perform an extraordinary feat of selective reabsorption and secretion. Each segment has evolved specific functions that work in concert to maintain homeostasis. Understanding these roles helps us interpret laboratory findings and anticipate complications in our patients. The proximal tubule handles the heavy lifting of reabsorption. This segment reclaims 65% of filtered sodium and water, a massive salvage operation. But here's what's remarkable. It reabsorbs nearly all filtered glucose, amino acids, and bicarbonate. When we see glucosura in a neonate with normal blood glucose, we're witnessing proximal tubular dysfunction. This segment also serves as the primary site for drug secretion, which explains why certain medications accumulate when proximal tubular function is impaired. The loop of Henle creates the kidney's concentrating ability through its countercurrent mechanism. Picture 2 pipes running parallel, but with fluid flowing in opposite directions. This design multiplies the concentrating effect. In adults, this system can concentrate urine to 1,200 milliosmoles per kilogram. Preterm infants, however, have shortened loops that limit concentration to about 700 milliosmoles per kilogram. This physiologic limitation means premature infants cannot conserve water as effectively, making them vulnerable to dehydration even with normal intake. The distal tubule and collecting duct provide the final adjustments. Think of these segments as the fine-tuning controls. They precisely regulate sodium and potassium balance based on aldosterone signals. The collecting duct responds to ADH by inserting water channels, allowing water reabsorption based on the body's hydration status. Without ADH, this segment remains impermeable to water, producing dilute urine. These functional differences have immediate clinical applications. When managing fluid balance in a 26-week preterm infant, we must account for their limited concentrating ability. When dosing medications, we consider proximal tubular secretion capacity. Understanding normal tubular function transforms our interpretation of electrolyte abnormalities from pattern recognition to mechanistic understanding, allowing more precise therapeutic interventions. The kidney's hormonal regulation centers on 2 opposing systems that maintain perfect balance under normal conditions. Understanding how these systems interact helps us recognize why certain clinical scenarios trigger predictable responses. The renin-angiotensin-aldosterone system, or RAAS, serves as the body's primary defense against low blood pressure and poor renal perfusion. When blood flow to the kidney decreases, specialized cells in the afferent arteriole detect this change and release renin. Think of renin as an alarm bell that starts a cascade of events. Renin converts angiotensinogen to angiotensin 1, which then becomes angiotensin 2, a powerful vasoconstrictor that immediately raises blood pressure. But the system doesn't stop there. Angiotensin 2 triggers aldosterone release from the adrenal glands, causing the distal tubules to retain sodium and water, further supporting blood pressure. Here's where it becomes clinically relevant. In conditions like renal artery stenosis or severe dehydration, this system becomes chronically activated. The constant RAAS stimulation leads to persistent hypertension. The kidney thinks it needs more pressure when the real problem is mechanical obstruction or volume depletion. This explains why ACE inhibitors work so effectively in these scenarios by interrupting this cascade. The natriuretic peptides, ANP and BNP, provide the counterbalance. When the heart chambers stretch from volume expansion, they release these hormones that essentially tell the kidneys to let go of excess fluid. These peptides promote diuresis, cause vasodilation, and directly oppose RAAS effects. Picture them as the brake pedal to RAAS's accelerator. In our NICU patients, this balance is particularly delicate. Premature infants have an exaggerated RAAS response, partly explaining their tendency towards sodium retention in the first days of life. When we see a tiny preemie with edema despite minimal fluid intake, we're observing RAAS dominance. Conversely, when BNP levels rise in an infant with patent ductus arteriosus, the heart is signaling volume overload. Understanding these hormonal interactions transforms our management from reactive to anticipatory. The neonatal kidney performs the same essential functions as an adult kidney, but with significant limitations that directly impact our clinical management. Let's explore each function and understand why neonates, particularly preterm infants, require such careful attention to renal physiology. Waste removal and detoxification represent the kidney's most fundamental role. Every metabolic process produces waste: urea from protein metabolism, creatinine from muscle breakdown, countless drug metabolites. In adults, efficient filtration clears these substances rapidly. Neonates, however, work with reduced capacity. Think of it like comparing an industrial-grade filter to a smaller residential model. Both work, but at different rates. This explains why drug dosing intervals extend in neonates, and why we monitor levels so carefully. Fluid and electrolyte homeostasis becomes particularly challenging in newborns. The kidney must precisely balance intake with output, while maintaining proper electrolyte concentrations. But here's the challenge. Neonates start life with 80% body water, compared to an adult's 60%. They're essentially managing a larger reservoir with less efficient pumps. Add their higher surface area to volume ratio, which increases insensible losses, and you understand why fluid management requires such precision. The reduced GFR in preterm infants compounds every other limitation. A 28-week infant filters at perhaps 10% of adult capacity. This means medications clear slowly, electrolyte adjustments happen gradually, and acid-base corrections take time. When we write orders for a tiny preemie, we're working within these physiologic constraints. Decreased concentrating ability creates another vulnerability. While adults can concentrate urine to preserve water during dehydration, preterm infants lack this safety mechanism. Their immature tubules cannot create the steep concentration gradients needed. Similarly, their limited sodium conservation means they waste sodium even when total body stores are low. This explains the paradox of hyponatremia. Despite ongoing sodium losses, the kidney simply cannot hold on to what the body needs. These limitations aren't failures, they're developmental stages. Understanding them transforms our approach, from fighting against immature physiology to working within its constraints. When we extend medication intervals, provide higher fluid volumes, or supplement sodium earlier than we might in older patients, we're respecting these physiologic realities. A thorough renal assessment in neonates starts well before physical examination, with each step building on the last to inform diagnosis and management. History is foundational. A family history of kidney disease raises suspicion for inherited conditions like polycystic kidney disease, reflux nephropathy, or other hereditary nephropathies. Even a vague mention, such as a relative with childhood kidney problems, warrants further exploration. Prenatal factors also offer critical insights. Oligohydramnios can indicate severe bilateral renal disease or urinary tract obstruction, as fetal urine is essential for maintaining amniotic fluid. Maternal use of ACE inhibitors or NSAIDs during pregnancy may compromise fetal renal blood flow at key stages, potentially leading to permanent damage. Perinatal events further refine our risk assessment. Perinatal asphyxia can shunt blood away from the kidneys, risking acute tubular necrosis. Infants with intrauterine growth restriction, IUGR, often have fewer nephrons and reduced renal reserve from birth. Recognizing these patterns allows early identification of infants at higher risk, sometimes before overt clinical signs appear. Physical exam findings can suggest underlying renal disease. Abdominal masses in newborns should be considered renal until proven otherwise. A smooth, palatable flank mass may suggest hydronephrosis or a multicystic dysplastic kidney. Bilateral masses may point to polycystic disease. Genitourinary anomalies such as hypospadias, undescended testes, or atypical genitalia often accompany renal anomalies due to shared embryologic development. Dysmorphic features like low-set ears, Potter facies, or signs of Vactorol association suggest broader developmental issues potentially involving the kidneys. Laboratory and imaging studies then confirm and clarify the clinical picture. Urinalysis can detect infection, proteinuria, or impaired concentrating ability. Serum chemistries establish baseline function. In complex cases, fractional excretion of sodium helps distinguish prerenal from intrinsic causes, while urine protein to creatinine ratios quantify proteinuria without relying on timed collections, ideal for neonates. Renal ultrasound is the preferred initial imaging modality. It's safe, non-invasive, and reveals key anatomic features like kidney size, hydronephrosis, cortical thickness, and corticomedullary differentiation. If further evaluation is needed, VCUG or nuclear medicine scans help assess urinary drainage and function. Each test is targeted, adding to a structured, layered understanding of renal status. Prenatal risk factors create the foundation for many renal problems we encounter in the NICU. Understanding these connections helps us anticipate complications and counsel families appropriately. Maternal medications pose immediate threats to developing kidneys. ACE inhibitors and ARBs directly reduce fetal renal blood flow by blocking the renin-angiotensin system. This isn't just theoretical. These drugs cause a specific syndrome of renal tubular dysplasia, severe oligohydramnios, and often irreversible renal failure. NSAIDs create similar problems by constricting renal vessels through prostaglandin inhibition. When a mother reports taking ibuprofen regularly during pregnancy, we must evaluate renal function carefully. Maternal diabetes affects fetal kidneys through multiple mechanisms. Hyperglycemia drives fetal hyperinsulinemia, promoting abnormal growth patterns, including renal hypertrophy. Preeclampsia reduces placental blood flow, creating chronic hypoxia that impairs nephrogenesis. These infants often show subtle dysfunction that worsens over time. Amniotic fluid abnormalities tell us about fetal kidney function in real time. Oligohydramnios suggests severe bilateral renal disease. Without fetal urine production, amniotic fluid disappears. Conversely, polyhydramnios may indicate urinary obstruction with overflow. Either finding mandates careful postnatal assessment. Fetal factors compound these risks. IUGR represents chronic placental insufficiency, limiting nutrients and oxygen during critical developmental windows. These babies have fewer, smaller nephrons, a deficit that persists lifelong. Prematurity interrupts nephrogenesis before completion. A 26-week infant misses 10 weeks of kidney development, starting life with perhaps 60% of normal nephron number. Prenatal ultrasound abnormalities provide early warning. Bilateral hydronephrosis, echogenic kidneys, or size discrepancies suggest problems requiring immediate postnatal evaluation. Single umbilical artery seems unrelated, but actually doubles the risk of renal anomalies. This vessel abnormality serves as a marker for disrupted mesodermal development, affecting multiple organs. Genetic factors underlie many renal diseases. Polycystic kidney disease, reflux nephropathy, and numerous syndromes follow inheritance patterns. Chromosomal abnormalities like trisomy 21 increase urologic malformation risk fivefold. When we identify these risk factors prenatally, we prepare for comprehensive evaluation at delivery, potentially preventing complications through early intervention. Physical examination of the renal system requires both systematic technique and recognition of subtle associations. Each finding connects to underlying pathophysiology in ways that guide our diagnostic approach. The abdominal examination centers on detecting masses, and here's a crucial principle. Abdominal masses in newborns are renal until proven otherwise. When palpating, use a bimanual technique with one hand supporting the back while the other gently explores the abdomen. Normal neonatal kidneys are rarely palpable, so any mass warrants investigation. A smooth, mobile mass in the flank suggests hydronephrosis or multicystic dysplastic kidney. Bilateral masses raise immediate concern for polycystic disease. The character matters too. A tense, fluid-filled mass transmits a different sensation than solid tissue. Abdominal wall defects like omphalocele or gastroschisis increase risk for associated renal anomalies. These defects represent disrupted mesodermal development that often affects multiple organ systems. Organomegaly provides another clue. Hepatomegaly with bilateral kidney enlargement suggests a storage disorder or polycystic disease with hepatic involvement. Genitourinary inspection reveals critical associations. Ambiguous genitalia immediately triggers comprehensive evaluation, including renal imaging. Why? The urogenital system develops from common embryologic structures. Disorders affecting genital development often impact renal formation. Hypospadias occurs when the urethral opening forms abnormally on the ventral penis surface. While mild hypospadias rarely associates with renal anomalies, severe forms with scrotal or perineal openings carry a 40% risk of upper tract abnormalities. Epispadias, with the opening on the dorsal surface, almost always indicates complex urologic pathology. Cryptorchidism shows a similar pattern. Unilateral undescended testis rarely associates with renal disease, but bilateral cryptorchidism significantly increases risk. The associated findings complete our assessment. Potter facies, that characteristic appearance with low-set ears, beaked nose, and micrognathia, results from severe oligohydramnios. Without amniotic fluid cushioning, the fetus experiences compression that molds facial features. This finding indicates severe bilateral renal disease. Ear malformations deserve special attention. The ears and kidneys develop during the same embryologic window. Low-set ears, abnormal shape, or preauricular tags signal potential renal anomalies. Vactorel association features remind us that birth defects rarely occur in isolation. When we see vertebral anomalies, anal atresia, or cardiac defects, we actively search for renal involvement. These associations aren't coincidental. They reflect disrupted developmental fields affecting multiple organ systems simultaneously. Monitoring urine output provides our most immediate window into renal function, and the expected patterns tell us whether kidneys are adapting normally to extrauterine life. During the first 24 hours, many healthy newborns produce minimal urine as they transition from placental clearance to independent renal function. By day 3, however, we expect consistent output of 1 to 3 milliliters per kilogram per hour. This range represents the kidney's ability to balance fluid needs while concentrating urine appropriately. The timing of first void carries important prognostic information. 90% of newborns void within 24 hours and 99% by 48 hours. When an infant hasn't voided by 24 hours, we begin investigating. The differential includes everything from simple dehydration to posterior urethral valves. That 1% who don't void by 48 hours almost always have significant pathology. This timeline helps us decide when watchful waiting becomes active investigation. Vital signs offer subtle clues about renal function that extend beyond simple blood pressure measurement. Yes, we monitor blood pressure trends carefully, using appropriate-sized cuffs and comparing values to gestational age norms. But heart rate patterns matter too. Persistent tachycardia might signal pain from obstruction or compensation for volume depletion. Bradycardia could indicate hyperkalemia from renal failure. The key lies in recognizing patterns rather than isolated values. An infant with progressively rising blood pressures over several days likely has renal pathology, while transient elevations during procedures mean nothing. Growth parameters and fluid balance work together to reveal the kidney's success in maintaining homeostasis. Daily weights provide our most sensitive indicator of fluid status. A 2% weight gain in 24 hours suggests fluid retention, while similar losses indicate inadequate intake or excessive losses. But here's what makes neonatal assessment challenging. Expected weight loss during transition can mask pathologic processes. We must integrate weight changes with intake and output records to distinguish normal adaptation from renal dysfunction. The concept of cumulative fluid balance becomes particularly important in sick infants. Rather than focusing on hourly variations, we track the running total over days. An infant accumulating positive balance despite appropriate intake may have impaired renal excretion. Conversely, persistent negative balance despite adequate intake suggests ongoing losses the kidneys cannot compensate for. This broader perspective prevents us from overreacting to normal variations while identifying concerning trends early. Laboratory assessment transforms our clinical suspicions into objective data, but interpreting these values in neonates requires understanding their unique physiology. Each test provides a specific window into kidney function, and knowing what to order and how to interpret results guides our management decisions. Urinalysis serves as our foundational test, yet neonatal interpretation differs significantly from older patients. Specific gravity tells us about concentrating ability. Expect values between 1.002 and 1.010 in preterm infants who cannot concentrate effectively. A specific gravity of 1.020 in a dehydrated preemie actually suggests good renal function for their developmental stage. Proteinuria occurs normally in the first week of life due to increased glomerular permeability. Values up to 1+ on dipstick mean nothing pathologic during this transition period. Glucosuria without hyperglycemia indicates proximal tubular immaturity rather than disease. Microscopy adds crucial detail that dipsticks miss. A few red blood cells and white blood cells are normal findings. However, cellular casts tell a different story. They indicate active renal parenchymal disease. The dipstick has significant limitations in neonates. It cannot detect tubular proteins, may miss significant proteinuria in dilute urine, and gives false positives with alkaline urine. When precision matters, we need quantitative methods. Serum studies require age-appropriate interpretation. Creatinine reflects maternal values for the first 48 hours, then gradually decreases. A creatinine of 1.0 at birth may be normal if mother's was similar, but the same value at 2 weeks indicates significant impairment. Electrolytes reveal the kidney's regulatory capacity. Watch for hyperkalemia with impaired excretion, hyponatremia from immature conservation mechanisms, and metabolic acidosis from reduced acid excretion. BUN rises with dehydration, but also with increased protein metabolism from feedings. Calcium and phosphorus abnormalities often indicate renal tubular dysfunction or chronic kidney disease. Specialized tests provide mechanistic insights. Fractional excretion of sodium distinguishes pre-renal from intrinsic renal failure. Values below 1% indicate appropriate sodium conservation in pre-renal states, while values above 2% suggest tubular damage. The urine protein to creatinine ratio quantifies proteinuria without timed collections. Values above 0.5 in term infants or 1.0 in preterm infants suggest significant proteinuria requiring investigation. These tools transform pattern recognition into precise diagnostic reasoning. Imaging provides our visual confirmation of what history, physical examination, and laboratory findings suggest. Understanding when to use each modality and what information it provides helps us make efficient diagnostic decisions while minimizing radiation exposure and patient discomfort. Renal ultrasound stands as our first-line imaging study for excellent reasons. Think of ultrasound as using sound waves to create a detailed map of kidney architecture. It requires no radiation, no sedation, and can be performed at the bedside. Crucial advantages in our fragile patients. The ultrasound evaluates kidney size, comparing measurements to gestational age norms. It reveals structural details like corticomedullary differentiation, which tells us about kidney maturity and health. When we see loss of this differentiation, we're often looking at chronic damage or dysplasia. Beyond structure, ultrasound with Doppler assesses blood flow patterns. This becomes critical when evaluating for renal artery stenosis or venous thrombosis. Hydronephrosis appears as dilated collecting systems. The ultrasound can grade severity and sometimes identify the level of obstruction. Masses, whether cystic or solid, have characteristic appearances that guide further workup. Even bladder stones, though rare in neonates, cast distinctive shadows that make diagnosis straightforward. The voiding cystourethrogram, or VCUG, serves a specific purpose. It's our gold standard for diagnosing vesicoureteral reflux. During this study, we instill contrast into the bladder through a catheter, then watch under fluoroscopy as the infant voids. If contrast flows backward into the ureters or kidneys, we've documented reflux and can grade its severity. The VCUG also beautifully demonstrates bladder anatomy, revealing trabeculations that suggest outlet obstruction and shows the urethra during voiding, essential for diagnosing posterior urethral valves in males. We can assess post-void residual, determining if the bladder empties completely. While the radiation exposure and catheterization make this test more invasive than ultrasound, the diagnostic information often proves invaluable. When we need functional information beyond anatomy, nuclear medicine scans provide unique insights. DMSA scans show functioning renal tissue, helping us determine differential kidney function, critical when deciding whether to preserve or remove a poorly functioning kidney. MAG3 scans evaluate drainage, distinguishing true obstruction from dilated but non-obstructed systems. CT and MRI reserve their roles for complex cases, where ultrasound cannot provide adequate detail, such as evaluating tumor extent or complex anatomical variants. We use these modalities judiciously, balancing their superior anatomical detail against radiation exposure or the need for sedation. Each imaging choice reflects our understanding of what specific question needs answering for that individual patient.